Dear friends, thanks again for your invitation. The title of my presentation is Does MHT Prevent Dementia or Cardiovascular Events? And first of all, I'd like to say something. I do hate the definition HT or MHT or PHT because menopause is not a disease and does not require therapy. So we need to avoid the therapy theory in counseling our patients, our women. Some women may suffer from hormone decline and therefore they do need a replacement. And when we know we are talking about replacement, we must take into account when we, for example, we are using patches 25, 50 or 100 patches, you see the effects in terms of circulating estradiol levels are very tiny. There are very tiny increase in circulating estradiol levels. So we do replace just a portion of what we are losing with a postmenopausal ovarian reduction and insufficiency. And therefore, we cannot talk about therapies, we need to talk about replacement. And the replacement has been reviewed in the last few years by the major societies, menopausal society, including the Italian Menopause Society. And talking about hormone replacement in postmenopausal, there are indications. And as I just cite for sake of simplicity, one society, the North American Menopause Society. And you see here that the indication approved for hormone replacement therapy are vasomotor symptom, prevention of both loss, premature hypoestrogenism, and geniturinary symptoms. But I'd like to underline the need to replace women that are suffering from vasomotor symptoms. Why? Because vasomotor symptoms is a cardinal symptom of menopause and perimenopausal period that is a marker of disease susceptibility related to negative mood, sleep problems, depressive symptoms, sexual function, quality of life, and also memory dysfunction with long-term metabolic consequences leading to lower bone density and osteoporosis, as well as subclinical cardiovascular disease, and finally, cardiovascular disease. Therefore, let's talk about the central nervous system effects of estrogen deprivation, mainly in women suffering from vasomotor symptoms. First of all, the symptomatic women, they usually underreport the number of objective hot flashes by a number of around 42%. And total number of objective hot flashes, sleep duration, and verbal knowledge were significant predictors of delayed verbal memory. So women that are very symptomatic, they do have an increase in the reduction of verbal memory, underlying the physical factors related to flashes rather than psychological factors predict poorer verbal memory. And these are data published many years ago by Pauline Mackey and afterwards also substantiated by other confirmatory trials. But first, I'd like to underline the role of hormone therapy, HT, hormone replacement therapy with the estradiol, published by Tommy Mikkola back in 2017 in terms of dementia, either vascular dementia and Alzheimer's disease type of dementia, and the women treated with estradiol-based preparation is associated with a reduced risk of death from both vascular dementia and Alzheimer's disease dementia, but the risk reduction is larger and appears sooner for vascular dementia rather than Alzheimer's disease, underlining that the effects of dementia is mainly due to the vascular effects of hormone replacement therapy. And you see that the standardized mortality ratio is significantly lower in women treated with both estrogen therapy or estrogen progestin therapy, both when they are younger than 60 or older than 60. And the effects are more relevant in women treated in women suffering from vascular dementia than in women treated with suffering from Alzheimer's disease. But definitely the effects are there also for Alzheimer's disease. So vasomotor symptoms may be an important determinant of cognition at midlife and beyond. And the vasomotor symptoms and brain health are linked with a different putative mechanisms. First of all, cardiovascular. Vasomotor symptoms have been linked to multiple indicators of cardiovascular disease risk. And we know that cardiovascular disease is a predictor of brain health. In addition, vasomotor symptoms are associated with elevated cortisol levels, and we know that hypercortisolemia is linked to the decrease in memory and executive functioning. So the rapid and sustained increase in cortisol levels every time that the human has a vasomotor symptoms may be related to an increase in the dysfunction of cognition at midlife. But also the blood flow. We know that during vasomotor symptoms, during hot flash, we do have a reduction in blood flow in the brain, of more or less a 5% reduction in blood flow in the central brain area every time we do have an increase in with a peripheral increase in vasodilation like we have during hot flashes. In addition, vasomotor symptoms can induce the sleep destruction, and we know that vasomotor, that their sleep alterations are very important in predicting the decrease in cognitive function in elderly patients, and therefore cardiovascular, cortisol, blood flow, and sleep can be associated, that all are induced by vasomotor symptoms can be causing also cognitive dysfunctions in postmenopausal women. And we need to remind that ovarectomy per se has been related to an increase in cognitive impairment and decreased cognitive performance in women. If we do perform an ovarectomy in a 45 years old woman, we must know that 30 years later, those women are at higher risk of cognitive impairment. So we do need to avoid unnecessary ovarectomies, mainly in women younger than 46. The relation between ovarectomy, estrogen, and dementia have been reviewed by Walter Rocca. Walter was doing a lot of studies regarding the effects of menopause, surgical menopause, and dementia. And we see that the ovarian conservation is correlated with a decreased risk of dementia. And the same apply with different studies showing that estrogen treatment in the early menopause is associated with a reduced risk of dementia. And there is dementia reduction is about 30% of the reduction risk. Anderson back in 2005 in the famous Mirage study demonstrated that these effects are related to the use of estrogens that is very potent. Conversely, when we do use estrogen, delay the post-menopausal period, like they did in the WHI memory study subgroup. I remind you that the mean age of those women that was 69, with the age range from 65 to 79, starting hormones when they were between 65 and 79 years of age. We do see no effects whatsoever, like in the Cache County studies, or an increased risk of dementia. But definitely nobody around the world was treating or is treating women with fairly high amount of oral estrogens in starting the treatment after the age of 65. So the highlights of the relation between estrogen and dementia can be seen that the effects of estrogen on the brain vary with age at the time of treatment. Estrogens produced naturally by the ovaries before the age of 50 is a neuroprotective. Estrogen treatment in the early menopause before the age of 60 may be neuroprotective, while estrogen treatment after 65 is harmful regardless of the type of menopause. And therefore, women who experience early menopause or premature menopause, naturally after bilateral ovarectomy, should receive estrogen replacement therapy. Therefore, as the British Menopause Society says that cognitive function in women appears to be affected by the hormonal changes after menopause. Late menopause may also confer some advantages, and the effect of HRT on dementia remains unclear, since studies are reporting conflicting results. Definitely, we cannot, as the Italian Menopause Society, we say that observational studies demonstrate that HRT may exert beneficial effects after surgical menopause. And the observational studies demonstrate HRT is associated with a lower Alzheimer's disease risk if we do respect the critical windows hypothesis, so with an early treatment. So critical is the timing of HRT beginning. If we begin HRT before the age of 60 or even 10 years from menopause, we may maintain the beneficial effects on the brain of the endogenous estrogens. But HRT shouldn't be initiated with the sole purpose of preventing dementia, mainly in women after 60-65 years of age. But please remind that the NANS underline that all the interventions that reduce cardiovascular risks, including smoking, weight management, regular aerobic exercise, the control of diabetes, hypertension, hyperlipidemia, may also reduce the risk of cognitive decline. And once again, we do see the relation between the health of the brain with the health of cardiovascular apparatus. And once again, we see the effects of vasomotor symptoms on cardiovascular risk. And we see clearly from the study of women across the nation, the SWAN study, that the frequent vasomotor symptoms is a potent risk factor for cardiovascular disease. These are the rate of cardiovascular events measured in women with less frequent and with very frequent vasomotor symptoms. And you see from baseline, we do see an increase by 77% of the risk in women with frequent vasomotor symptoms. So therefore, menopausal vasomotor symptoms are a risk factor for cardiovascular disease events in postmenopausal women. And in this old slide, we depicted the apparent discrepancy between the observational studies and the WHI in terms of cardiovascular ultimate effects of hormone replacement after menopause. Because the estrogen preventive action requires healthy tissue, requires the estrogen receptors. And we need to remind that the estrogen receptors are methylated. They almost disappear with the beginning of atherosclerotic lesions. And therefore, when we study hormone replacement effects in early postmenopausal women, when they are 40, 55, and the effects of atherosclerosis are not so prominent, like when they are 65 and older, we see that here estrogen can act and reduce the endothelial dysfunction. When we do have atheromas all over, fibrous plaque, or even complicated lesion and ruptures, like in WIMS, when they were 69, the medium age of the WIMS were 69. Here, for the WHI was 63. 70% of the women in the WHI was 63. So we need to understand that HRT in postmenopausal women, in elderly postmenopausal women recruited for the WHI, due to the stage of atherosclerosis progression, couldn't be effective in reducing the cardiovascular disease, but they could increase the procoagulant effects, the complications of lesions and ruptures of the plaques. Therefore, it is vitally important to understand that the timing of HRT initiation is critically important. And in fact, meta-analysis of randomized controlled trials shows the hormone therapy initiated fewer than 10 years after menopause, according to the Cochrane database of 2015. We do see a reduction of coronary heart disease by 50%, with a reduction of 30% in mortality. And this Cochrane review is confirming the famous meta-analysis of Salpeter showing the odds ratio for total mortality, that cardiovascular hazards, they do not exist in women over less than 60 years of age when they do initiate hormone replacement therapy, while women initiating over 60, they don't have any positive or negative effects in terms of cardiovascular disease risks. And these data were also confirmed at the WHI, because in the subgroup of women, the 30% of the women that they were younger than 60, treated with conjugate equine estrogen and the worst progestin they could even choose, the MPA, there is a reduction of about 30% of risk of mortality. And these effects are also present in the 18-year cumulative follow-up. According to the 10 years age group and randomization, in the 10 years in younger group aged 50 to 59, after stopping hormone replacement therapy, after 18 years, they do still have an 11% risk reduction. And please take into consideration that the risk reduction is similar in the WHI, 30%, 33%, and 32% in the meta-analysis of 23 trials published by Salpeter back in 2006. So keep in mind that the window of opportunity was confirmed by the WHI trial. And this is vitally important when we are counseling our patient, talking about perceptions, fear, and prejudices about the HRT. And the same apply for the DOPS, the Danish Osteoporosis Prevention Trial. Here, after 11 years, they stopped the trial, and the control group was still different from the HRT group in terms of death or admission to hospital for heart failure or myocardial infarction, that was significantly lower in women treated with hormone replacement therapy. I'd like to finish my presentation talking 1 minute about the osteoporosis. Menopausal symptoms, vasomotor symptoms are related also to an increased bone lower bone mineral density, and higher fracture rate. And it has been repeatedly demonstrated that HRT reduces total fracture, hip fracture, and vertebral fracture by 26%, 28% reduction in hip fracture, and minus 37% of vertebral fracture. And the relative risks are similar to those of bone-specific drugs. And I'd like to underline that bone-specific drugs like bisphosphonate never have been demonstrated that to be able to reduce fracture in osteopenic or postmenopausal women, while hormones, including tibolone and the serums, are used to be demonstrated that are able to reduce the fractures also in osteopenic women. And therefore, both the British Menopause Society, the International Menopause Society, the Italian Menopause Society, the NAMS, they clearly state that the estrogen deficiency and menopause is the primary cause of bone loss, and the hormone therapy is the most appropriate choice to prevent and treat healthy women, particularly those who have menopausal symptoms, in order to prevent postmenopausal osteoporosis. And as it says that, dear friends, I'd like to finish my presentation, says that systemic HRT is essentially indicated for symptomatic women aged less than 60 or within 10 years since menopause. Please remind, hot flashes are not just a symptom. They underline the brain susceptibility to estrogen deprivation. And therefore, according to the major menopausal society, we can say that as far as cardiovascular disease is concerned, early HRT in healthy women have the potential to reduce cardiovascular disease risk and mortality. And HRT should be considered first-line therapy for osteoporosis, just because benefits are likely to outweigh risks for symptomatic women who initiate hormone therapy aged younger than 60 years or within 10 years after menopause. Thank you very much for your kind attention.